So first, I'd like to introduce Dr. Wang. Dr. Wang is a clinical research fellow at Harvard Medical School and associate physician at the Brigham and Women's Hospital. During her fellowship at Stanford, she studied hypertension and cardiovascular outcomes. And her current research focuses on investigating the role of bioimpedance analysis and biomarkers in aiding clinical decision-making. Her other interests include the implementation and evaluation of patient-centered interventions to improve outcomes in persons with end-stage kidney disease. And she was the CSN Nephrology Fellow Award 2018 to 2020. And with that, we'll let Dr. Wang take it away.
So hi, everyone. Good afternoon. I'm Katie, and thank you so much for being here today. And thank you for the AKF for allowing me to present my research to you. So the title of my talk is Sprinting to Intensive Blood Pressure Targets for Whom and How. And I just wanted to start by sort of introducing the problem, which is high blood pressure, and that is the focus of my talk today. So high blood pressure or hypertension is diagnosed when your systolic blood pressure, or that top number, is greater than or equal to 130, or a bottom number, the diastolic blood pressure, is greater than or equal to 90. And most of our recent research has been focused on systolic blood pressure because it has a greater relationship with the outcomes of cardiovascular disease. And so I'm just going to focus on that top number for the remainder of my presentation today. So we know that high blood pressure is associated with various health outcomes, including heart disease, kidney disease, strokes, and even death. And the prevalence is very high in the United States. These numbers are from 2017, 2018, but about 45.4% of adults, or 103 million folks, were diagnosed with high blood pressure. There's also severe economic consequences and burdens. So in terms of estimated cost of high blood pressure related expenditures, in 2023, it's projected that we'll spend over 200 billion. And in 2030, when we anticipate another 27 million adults being diagnosed with high blood pressure, at that time, our total cost will exceed 389 billion. So as you can see, this is a very important topic with significant consequences for everybody really involved. Next slide, please. So that leads us to the question of what is the optimal blood pressure target? There's been a lot of research regarding the best blood pressure target for patients. And in 2015, SPRINT was published. This was a multi-center study that enrolled 9,361 folks with high blood pressure and at high risk for cardiovascular disease. And they were either treated to a blood pressure target of less than 120 or a standard blood pressure target at that time of less than 140. And what SPRINT showed was a remarkable risk reduction in fatal and non-fatal cardiovascular events. So these include heart attacks, these include stroke, heart failure, and also a 27% risk reduction in all-cause mortality, so death from any cause. As you can see, the findings are very significant, and what makes this a landmark trial. What's also pretty significant is that the time that SPRINT was published, approximately 1 in 5 Americans being treated for high blood pressure would have been eligible to enroll at that time. So what does this mean? Well, a lot of times when we do research, there's all sorts of exclusion criteria, and people wonder, would I have been eligible for this trial? And as you can see, 1 in 5 would have been, and that makes this this research study and the question that it posed very relevant to the public. Next slide, please. So what I tried to do in this research project is, because, you know, SPRINT pretty much established what our best blood pressure targets that we should be aiming for in this patient population should be, but we also wanted to ask, well, what are sort of the caveats in terms of, you know, healthcare providers who treat patients with high blood pressure? What sort of things should they look out for in patients who are not able to achieve an intense blood pressure target? So we aim to look at factors associated with failure to achieve the intensive blood pressure target. And the hypothesis going in was that demographic factors, including older age, Black race, male sex, and higher BMI, as well as baseline conditions, including having a history of chronic kidney disease or having a higher blood pressure at baseline, would associate with lower probability of achieving target. And the reason for this is that, you know, previous literature have shown us that in terms of population health studies, folks that are older, folks of Black race, and folks with higher BMI, for example, may have more difficult to treat blood pressure. The other thing I wanted to incorporate was how occurrence of a serious adverse event, because we always worry about treating blood pressure too low or sort of the other side effects of the medications that we give. And so how would occurrence of one of these events during the trial, including blood pressure that's too low or somebody passing out or falling because of the treatment, would affect the ability to achieve the blood pressure target. And the hypothesis was that having one of these events would sort of make it less likely for folks to achieve that intensive blood pressure target. Next slide, please. So again, the outcome was seeing whether or not folks could reach the blood pressure target by target group. And I'll focus on the intensive target a little bit later. And essentially what I did for this project is that we looked at 60 baseline variables and we included them into the model based on our hypothesis of how they would associate with the outcome above. And so we looked at baseline demographics, comorbid conditions, biometric information, medication labs, really as much information as we could include that we thought was relevant. And then in terms of the serious adverse events, that includes low blood pressure, passing out, heart rate that's too low, sort of lab abnormalities, falls, or acute kidney injury. Next slide, please. Oh, sorry. Back one more thing. And the other point I wanted to mention is that, so the model that I used in my project incorporates time varying covariates. And all this means is that, the variable may change with time and the outcome, the outcome may change with time. So at 3 months, if you're less than 120, that's called achieving the blood pressure target. But obviously people fluctuate. So if that same individual at 9 months has a blood pressure of 140, that counts as not achieving the target. So this way we can sort of leverage longitudinal data and see how somebody does over time. Next slide, please. So this is really a brief overview. On the y-axis is a percent of folks that are able to reach the blood pressure target. And on the x-axis is sort of the months since enrollment. And there's 4 groups, but essentially the 2 lines at the top are the folks randomized to the standard blood pressure target of less than 140. And as you can see, within 3 months, they pretty much are able to reach sort of their blood pressure targets for that group and then sort of stay there with some fluctuations. And the bottom 2 lines are folks that are randomized to a blood pressure target of less than 120. And the differences between the top 2 and the bottom 2 is also whether or not folks have chronic kidney disease. And as you can see, the folks with chronic kidney disease actually have the toughest time reaching their blood pressure targets. This is a graph of the mean cumulative visits at goal. And so on the y-axis is a cumulative number of study visits where they had their blood pressure measured and recorded. And on the x-axis is, again, sort of months since randomization. And so this shows that the number of cumulative visits, so the number of visits over time where they did not reach the intensive blood pressure targets. And again, as you can see, folks that are randomized to the intensive group, so the lower systolic blood pressure have a tougher time reaching their targets over time. Does that make sense? So yeah, so basically there are fewer visits in which the folks that are randomized to the lower blood pressure target are meeting their blood pressure targets compared to the standard group. Next slide, please. And so focusing on the intensive treatment group, because we know that there were various health benefits associated with being in that group, I looked at the factors associated with not achieving the blood pressure target. And so the folks that had lower odds or lower probability of achieving their intended blood pressure target included folks that were of older age, of female sex, that had higher blood pressure at baseline, history of chronic kidney disease, or had one of those adverse events that I described prior. And so these results are not very surprising. They were kind of what we thought going in. Next slide, please. But what was interesting were a couple of things, not everything that I had hypothesized in terms of barriers of reaching a lower blood pressure target, such as Black race, panned out. And as a matter of fact, there were two specific groups that had higher probability of achieving the blood pressure target. And this was not something that I had thought about beforehand. And that was folks that were of Hispanic race and had a higher BMI. So folks in these subgroups actually had a higher probability that they were going to reach the lower blood pressure target. Next slide, please. And so the question is why? So just briefly, in prior studies using population level data, Hispanics have traditionally had lower rates of high blood pressure awareness, treatment, and blood pressure control. And also, but then when I dug a little deeper, there were actually two prior clinical trials that looked at blood pressure outcomes. So similar to SPRINT in that they were treating high blood pressure, but they showed participants of Hispanic ethnicity did not actually associate with inferior blood pressure control compared to their non-Hispanic counterparts. And so the hypothesis is that, you have these three big trials. So including SPRINT, there was also ALL-HAT and INVEST, and they all sort of show that actually Hispanic folks that self-identify as of Hispanic ethnicity don't seem to do any worse in terms of blood pressure control, and in some instances actually did better compared to non-Hispanic counterparts. And so the thought is that better blood pressure control in the subgroup occurs when traditional barriers to healthcare are removed, that they have when they are availed to access to equal medical care, such as in these clinical trials, or that they're provided with medications at no cost, they are just as capable of achieving, if not better, blood pressure control. The other thing I wanted to mention with BMI, so one of the original thoughts going into the study is that prior research has shown that being overweight or obese actually associates with having a higher blood pressure, or having a new diagnosis of high blood pressure. And this is the thought originally, that they might have worse blood pressure control, which did not turn out to be the case. And so the thing to remember here is that, high blood pressure affects folks of all shapes and sizes. And, we see high blood pressure rates, also that are also pretty significant in individuals with low or normal BMI. And the other thing, digging a little deeper and sort of thinking about this, that there may be other measurements that, for example, incorporate central fat distribution that may more accurately assess obesity-related conditions. And so these are some things to think about both in this project and sort of going forward, that we're not just sort of discounting certain subgroups or kind of chalking it up to, a comorbid condition or something genetic or biological that sort of predisposes them to one outcome, but that we're sort of thinking about a person as a whole. Next slide, please. And so in conclusion, there's been a lot of research, especially recent years, that supports the merits of intensive blood pressure control, and that we should continue to efforts to optimize blood pressure control because they can lead to meaningful improvements in public health. And then having awareness of these risk factors associated with either the ability or inability to achieve a blood pressure target can guide our clinical decision-making, facilitate personalized treatment plans, and inform population level initiatives in maximizing the benefits of blood pressure control. And sort of the takeaway message is that despite evidence that intensive blood pressure control can improve health outcomes and decrease mortality, we have to be aware that certain patient subgroups may face greater challenges in achieving our recommended blood pressure targets. And sort of the next steps would be sort of both increasing awareness of this and then also implementing things that should sort of mitigate these difficulties. And then just, I'm probably over time, but just very briefly, I just wanted to say thank you so much to the AKF for choosing me to be a CSN fellow. I feel like I've just gotten so much out of this experience. And yeah, I just listed some other projects that I did and things like that during these past couple of years. And I wanted to say thank you so much to Glenn, who I think is watching, just an incredible mentor. He received this same fellowship, I think he said 35 years before I did, and then 36 years before Pablo did. So what an incredible legacy, and to have trained with him and worked with him, just amazing. And also thank you so much to Tara Chang, incredible mentor as well, also a mentee of Glenn's. And so yeah, it's just been an incredible experience, and thank you so much.